So obviously this is not a question that we can answer now in the next 10 minutes. Some cases with simple disc herniations might be very difficult to solve. For central disc herniations, there are very few facts in the literature. They have a worse postoperative outcome than simple herniations. They cause a derangement of the disc architecture and the posterior ligament, and they have a higher incidence of recurrence. So the question is always to fuse or not to fuse, sometimes very difficult to answer. Patients that have significant back pain, bony edema, and a big disc height usually tend to need the fusion. Patients that have unilateral symptoms, no back pain, are young, have small disc heights, low BMI, might get away without a fusion. So, I mean, a single-length fusion, especially if you do a lot of MIS, is actually nowadays a minor procedure, but that doesn't mean that everybody needs screws. So you have to go to the individual history of every patient and radiological signs in order to make the right decision. So I start with a case of a 37-year-old female patient, 60 kilograms, 165, pretty active, denies back pain, has right-sided sciatica, and is neurologically intact, and comes with this image.
No back pain.
No back pain. Open for discussion. So who would do a fusion in this patient? And why? I know Costa's opinion, so... How many probably abdominal surgeries does she have? So is there somebody that would treat this patient without the fusion? Yes? One. Two.
I would risk it.
You would risk it. Okay. Can you explain why?
Because of her age, I think this disc is reachable, the anatomy is favorable, and there is a degeneration of the L5 as well. It looks like there is a lower lumbar lordosis that would make things difficult to deal with if you do a fusion and it's revision. So I would risk just taking this disc out. I give her a warning that she might need the fusion as a second operation. But yeah, I don't know what you did.
Of course, I fused her. So since my orthopedic colleague wants a decompression, I did a fusion. I felt that there is also the issue of the recurrence, and I think from my point of view, one of the major complication of discectomy is a recurrence, which makes our life much difficult in the second operation. So in this case, she has a very big defect on the disc. The disc herniation is very large. The disc is dehydrated. So
who would do a fusion here?
Nobody, just me.
Who would do just a discectomy?
All right, perfect.
The question is, if you do a fusion, I mean, in my mind, I guess she will need a two-level fusion.
Why?
Because maybe after the fusion you have a symptomatic of fibrous one. I think that would be one of my worries.
Why?
Huh?
Why? I mean, she doesn't have, preoperatively, she doesn't have back pain.
Yeah, but so this is the case. I understand that it's a wide, to be honest, we based discrimination, and your point in the possibility of recurrence is correct.
The recurrence of the back pain.
Recurrence
Of a herniation.
But on the other hand, the issues are the same. She doesn't have a back pain, she only has a leg pain. 36 is active. Okay, let's give her a discectomy.
Yeah, but you said if you do.
If I did, yes, I would consider
but see, I'm very happy I can still put an A-lift there, if need be. Instead of having to deal with a two-level fusion with no lordosis, I mentioned all this, all these issues, but you definitely won't get a recurrence of this, for sure.
Well, it's interesting because we've moved backward. It's like you said, so usually this case you presented, which is actually slightly hypotic on the MR.
Yeah.
So even the standard X-ray may show she's hypotic.
Exactly.
So you've got all those correct deformity principles, but I guess for us, for me, it's just that we've been stunned so often that now, again, it's that whole point, is what's salvageable? So it's salvageable. If I did a discectomy and she came back with trouble, fine, I'll do something there. But I think if I could get away without doing anything more, that's where I would come from with this. And what would I want? So if this was me, I just want a discectomy.
I have a couple of things with this picture that the post-op alignment
It's better.
is better.
Yeah.
So standing better, I did some exercises in the movement, but alignment is better. It's just a discectomy. So it's an option. It's an option. That's what I want.
Okay. So number 2, 31-year-old, 75 kilos, 163, mechanical back pain, left-sided sciatica, 2 epidurals, minor improvement, neurologically intact. Discectomy.
So what are the options here? Discectomy?
Discectomy.
The configuration of the anatomy of the disc herniation favors discectomy, and it's
Well, what do you mean by that? Because I always look on the size of the herniation. I mean, she has a rupture, and here it's there. And she, this 5 is 1, 5 is 1. And she has a minor bony edema. She has also lack of lordosis. Okay.
Because that disc looks completely disrupted. She's got body stages, facets disorganized with inflammation. I think the risk of recurrence here is high, but this is my gut feeling. I can't support it with evidence. I would probably have done a fusion.
So why fuse this one not the last one? Because the last one was worse in terms of the broad breadth of the herniation. She had a kyphotic angle.
Yeah.
She had degenerative templates as well. So why? So this one even more out of discectomy. What's made you feel different? She's better than sure though. What's made you feel different about this one?
No, I felt that the first one, there was a clear difference. Can you go back to the provision?
Yeah.
There is a clear separation on the axial in between the disc herniation and the disc, the corpus.
Okay.
So I think it's just the stuff that has come out, and there is no continuation of the pathology with the central disc. If I can explain it.
You mean a failed fragment without any, from a small under there, is that big?
While on the other MRI scan, it looks like a completely.
Do you still miss him from him? Huh? Do you still miss him?
I think if you do a discectomy, you probably take the whole disc out with one bite in this one.
It's interesting. I'll be honest with you, if I had to pick one for each, I would have fused the first and discectomized this one. But I would do discectomy on both of them anyway. But if you force me, which one would you fuse, which one would you discectomize, I would do the opposite. So it probably shows that there's nothing right. just do the discectomy because it's the simplest and easiest.
Even if you do a fusion,
that's why I'm provocative with this discussion.
Even if you do a fusion, you might still
That's what I believe.
getting a disc on the other side. For example, I've had patients who have disc on the other side. Some of them conservatively develop disc on the other side. Some of them operated on them and they develop disc on the other side, despite they remove this one. Even with fusion, I had some putting kids in there, they had this coming up on the other side. So it might happen. So a fusion will not save you from the recurrence. And
Of course, why not? Fuse there.
Up to now.
I mean, this is clear in your surgical case. Huh?
To fuse? No, not to fuse.
So let's go for number 3. 40-year-old female patient, 57 kilos, 170, right-sided sciatica, perigenital burning sensation, no motor deficits, unable to stand or walk due to pain.
This is clear what I talked about. First one.
This is a separate thing.
Well, there are two fragments there.
Yeah.
There's one fragment which is there, there's another fragment with a big opening. But still, this is not something that I would consider as a big indication to fuse or not fuse.
I think that the first limit you see, it's a chronic disc.
Mm.
Yeah. Agree? And there is a reasonably big canal, spinal canal.
She has herniation.
Herniation.
She had herniation. She has
Yeah.
symptoms of
Herniation.
Yeah. And exactly, and for me, this is a case that I don't fuse. If they have codoquina, try to avoid that. Try to put any instrumentation.
Try to avoid.
Yeah.
Because
I don't know. I feel that the thing is they have a neurological compromise due to compression, and if they're totally unstable, then you have to do that. Okay, but in this case, I mean, I would go just for the disc, see how she is afterwards, and I would avoid fusions. I wouldn't put screws in codoquina. I wouldn't do that.
so this compared to case 1, the only difference for you not to fuse this one is
Well, she's not kyphotic, okay, and her facets are better. She had a very big canal, and she had codoquina, so I said, okay, just go for the disc. I didn't fuse her.
Congratulations.
27-year-old, right-sided sciatica, no motor deficits, professional athlete. Easy, right?
with leg pain. So you said leg pain.
Excuse me?
Has got pain, radicular pain.
Yeah, radicular pain. Yeah.
Right.
Right leg.
No left leg symptoms.
The best thing is to discuss the option. about
Right-sided
the
sciatica.
process.
Is there anybody that would fuse this patient?
I mean, is there anything against
Discectomy.
here? Do you feel that there is anything that would make you decide against discectomy?
One side or two sides?
Right side.
Right side.
Right side.
Right side pain.
It fits.
I asked you any choose to discectomy side. One or unilateral or bilateral?
I think you
One
can
side.
reach it from the
No, right side.
symptomatic side, which is the right side. But if you are not happy with how much you can get out from that side, you can always go from the other side.
Other side is asymptomatical, but this is very diffuse. This in there. If you make any bilateral micro discectomy, is a good result.
It's an option. Okay, it's an option.
You do the right side, you have a good result, this result. Yeah. On the left side, you get CSF lead, nerve injury, and you just say potential possible. Because one side is enough to do total remove to this, and other side is usually to the pain and the other disc. I'm just saying that if you go on the left side, the left side, you turn the disc out, relatively happy, and no problem from there, and you go on the left to complete with something better, and you end up with a problem. You will say bad diagnosis. But next 6 months, you will come here to the other side problem.
Might be. But maybe not.
Do you actually look at the anatomical configuration of the lamina or the size of the canal to base your decision? That's what I'm asking.
This patient is very young.
Yes. It's very young. But very steep lamina. There. Relatively small canal, not congenital narrowing.
After the discectomy is not bilateral.
I won't argue about that, but my point is that this is technically more demanding discectomy than the previous one.
Yeah, definitely. Mm-hmm. So, yeah, sure, of course. So this is the last one. This is a 25-year-old that has mechanical back pain, right side sciatica, and no deficits, and this image. No abdominal surgeries.
As he had kids.
I'll be honest, I'll just do a discectomy again. I think, rightly or wrongly, all of the cases I would probably try a discectomy first.
Well, the issue is, no, this is what Costa said. He has two components, and he has this chronic disc and this small fragment on the right side. And he hasn't been operated yet. I'm trying to avoid that. He's 25, and this is like going 3 months. I mean, he's coming every month. He's still having right side pain. I'm trying to. I wanted to give him an epidural, some time. I don't feel that this is a good option for surgery. If we start surgery, this can end to a disaster, starting with a discectomy. In 25. Yeah.
And he can live with the black.
Yeah, but that's I don't know if somebody will do it, but if you can accept all this and you remove all the fragment. If it's just right side leg pain,
it is.
Remove the whole.
It is.
What will happen
if you remove the
remove the fragment and the whole disc comes out.
Yeah, but it's a young patient. I mean, he can go for years. You can tell him that it's okay. It's a big issue, but it's not for the.
But still, there is a chance you can get it without.
I mean, he's 25.
Is the first option. Yeah,
The debate is no surgery.
well, we all feel uncomfortable sometimes. Where you have a huge disc rupture, like this, where it's slightly generated disc space. But in young patients that are symptomatic in the past years of their life, and they have leg pain, you can talk to them and say that it's an option. This is the first option. I think we can agree with that.
Sorry, the first option is?
Discectomy.
I mean, you're absolutely right about conservative first. Sorry, yeah, absolutely. I would try and avoid it if it reabsorbs, you're fine.
Yeah.
But when you say, let's say it comes to discectomy, the disaster would.
Disaster for me would be that he gets a recurrence, and then he gets a fusion 5S1, and he has a black disc on 4-5, and then you extend, and he's 25, and this can happen within 3 or 4 years.
So do you think so if we're sticking to discectomy actually, do you think discectomy increases the chance of recurrence?
Yeah.
Because there's no data to show that.
I mean, it depends on the damage the disc has, but this is a degenerated disc, so this is soft tissue. And he has a chronic disc, so
that's him.
Yeah.
So you doing a discectomy is going to increase.
No, it's not my surgery that's going to doing, but he has a chance of getting a second disc herniation.
But obviously, if it doesn't get better than so, then you have 100% recurrence of this because it doesn't get better.
Yeah.
So in this case, you have to do something.
Yeah, and this is. I mean, he's going to get a discectomy if you can't do anything, but I would try to avoid that.
Yeah. But mechanically, but this thing, the disc, the fragment is already in the long place. I mean, no matter what, the disc works differently from now on to the future. I mean, whatever you do nothing, you do a discectomy, the mechanical environment is different.
the black disc in L5 or 4 will continue to degenerate no matter what you do. The L5 will degenerate and will mechanically act in a different way no matter what you do because there's no.
Yeah, but you don't know the timing. Yeah, you don't know the timing. He might live 20 years with this kind of situation.
It's irrelative if you operate on it. You just take the pain out. That's it. The fragment.
So you mean a discectomy does not leave any signs of removal of part of the lamina and a part of your flavum?
You don't discapitalize the spine if you do just a limited.
Even because it goes upwards, that's the concern.
I mean, you have to expose it and take it. You have to do some kind of surgery. So his spine is not going to be a 100% normal spine afterwards, even if you do this minimally invasive.
The fragment is out. The disc is still has a completely different way of working.
Again, those 80% they get better on their own.
Yeah.
Yeah, also
Yes, we show you had patients that had a second scan and they're going to say very, very good removal of this scan. They had no operation.
Okay.
Might be.
You will improve by radical block and crowd animation.
Okay.
Just for dependency.
What?
Radicular block.
Radicular block and crowd innervation. You will improve.
Is that some conservative stuff?
Yeah. You put the pain, so you give some time to absorb.
Yeah, he doesn't want to operate and he wants to offer something. Radicular block and crowd innervation.
Much back pain is a
I don't think. Yeah, he has back pain. Yeah.
Okay, how many months do you think you should wait for a symptomatic patient to have a discectomy?
Well, it depends if he's functional or not functional.
Okay.
I mean, he walks around, but he's 25 and he has expectations. He wants to play football. He wants to do things.
Maximum 6 months.
Huh?
Maximum 6 months.
Okay.
Because they ask you.
Because I don't think there is a point of waiting more. Based on the